do that.
Okay, great. So Professor Bhatia, I'll call you Kailash because we've been good friends for a number of years now. I wanted to learn a little bit about your journey. What inspired you to go into medicine and neurology? Teach us a little bit about what your passion has become in treating Parkinson's, and also why this interest in, it seems like you're really quite interested in dystonias and sort of this intersection. Maybe you could teach us a little bit about that.
So I have a, I don't know where to start. It's a long journey. I trained in India, in Mumbai, and I moved to the UK, blimey, a long time ago, over 20 years. And I trained initially in neurogenetics with a very famous professor called Anita Harding, and then subsequently trained with another very, very famous person who actually is considered, along with Stan Farn, as one of the fathers of the field of movement disorders, namely David Marsden. So I was his last fellow, and then I continued at Queen Square and slowly went up the rung, and I am here now. Why the interest in dystonia? Well, actually that rubbed off onto me from David Marsden. David Marsden had a great interest in dystonia, and obviously had a great interest in Parkinson's as well. So it was his, I guess, his interest and mentorship which led me into that field. So yeah, that's a little short summary of the journey.
That's amazing. Well, I know you have been doing a lot of work internationally as well with the Movement Disorder Society, and you've been working all over the world, really. You're still very involved in the Movement Disorder Society of India, helping teach a lot of the students and trainees there about, how to approach movement disorders and, the very sort of meticulous way to piece together these different movements and understand sort of the clinical picture as we've kind of been talking through here with, what's the difference between a dystonia versus a tremor versus these other things. So we might sort of ask some questions around that, but I think there's also been a lot of interest in activism in patient groups, I think now, about worldwide causes and global causes of Parkinson's, including lack of medications in some parts of the world and lack of access to care. And I know you've been very involved in some of these things. So maybe we'll spend a little bit of time meandering around some of the things that have come up just in the questions around your talk in the dystonia arena. But then also I'd love to hear, if we have time, some of your thoughts on activism, advocacy for patients, and where you think we need to go as a group of doctors and patient support organizations, as well as patients and carers around the world who really should be caring about not just ourselves, but the global cause of Parkinson's, which I think has been currently termed a pandemic. And I think COVID and its pandemic has really kind of shone a light on a lot of these sorts of problems. So maybe we'll spend some time, and if the group has
maybe if you don't mind me interrupting, I just want to make a comment here. I think you touched upon a important topic. I think one of the things, both for patients and for doctors, is that movement disorders is a tricky field. So it's very clinical, and it's very important, therefore, for young doctors to learn the clinical skills. And even if you just take Parkinson's, there are so many different forms of Parkinson's. Every individual person is different in Parkinson's. The management, therefore, has to be very individualized. So although we are grouping together everybody under this rubric of Parkinson's disease, if you look at individuals with Parkinson's, you realize that there are a number of differences between them. Their response to treatments, their those who develop dyskinesia early, those who develop dyskinesia later, those who develop dystonia, this, that, etc., those who have a genetic form, those who don't have a genetic form. So although we are lumping this under one umbrella, there are these certain nuances, certain differences, and this has to be very much kept in mind when we are talking about personalized medicine. And both the doctors and the patients have to be aware of this. And I think this education has to be spread, as you said very rightly, not just in our countries, but where we are practicing, but all over the world, because this is something which is present all over the world. And I very strongly believe that, like you said, for COVID, there are no boundaries. And for diseases, there are no boundaries. And, people have a right everywhere to get the best possible care and attention. Exactly.
Absolutely. And I thank you for, I mean, your work. You've literally traveled to so many corners of the globe. And I know that you've been doing a lot of even video sorts of looking at patients. And you've trained so many fellows that have come from literally every corner of the globe, that you have this kind of network of fingers kind of across the world of people who then gather cases that then send to you. And then you're able to kind of collate them and then do these studies to really advance the field. So I think it's really amazing. But I think also a lot of what we're talking about here, because this is a patient forum, is really to get patients to advocate for themselves, to get them educated, to know that, there are these sort of experts like you and these sort of areas where we can really try to advance, so if they're seeing a doctor and they're not getting sort of the, the attention or getting better in some of the things, perhaps there are things that are being missed, because I think many of these topics are getting not just specialized, but sub specialized, where there's, literally an expert in Parkinson's dystonia or genetic dystonia. That's, so I think, the sort of hope is to continue to collaborate and converse and keep the conversations going. So I really, appreciate your strong work there. Kailash, you had talked a little bit about SWEDs. People want to clarify exactly what that means. Maybe you could teach us a little bit about
So
the SWED.
what was so the background to this is that in a number of studies, drug trials, it was realized that a number of people who were being diagnosed clinically as having Parkinson's, when they had a scan, a dopamine transporter scan, or a scan which is called a fluorodopa scan, to look at the brain dopamine activity, which we know that in typical Parkinson's is reduced in about 10 or 15% of them. In 3 different studies, patients were being recruited as having Parkinson's, but they were actually, they had normal scans. So they were actually excluded out of the study because it was felt that they don't have Parkinson's disease. So the name given to that was scans without evidence of dopamine deficit. That's how the term SWEDs came. And then there was a lot of debate as to what do these people have. And obviously they can have different things. Some of them have some type of essential tremor. Some can have, Dopa responsive dystonia or something else. But we felt that there was a subgroup of people who present with this type of tremor, which we think is a dystonic type of tremor, and they continue like that, and a small number of them convert to Parkinson's, but a number of them carry on for years just with that tremor. And they don't respond well to the classic medications we use for Parkinson's, not surprisingly, because they don't have the dopamine deficiency in the brain.
I think we're frozen.
Yeah. Do you think it's a shitty log off and log back on, or? Okay.
There are patients, no, because the scans are not available. So it was not approved by the FDA.
You actually froze for a second, Kailash. Just when you were talking, you had just said that scans are abnormal or are normal, and they may have, what do they have? You talked about the tremor, but then you froze for a second. Could you just repeat the last what you just said? Sorry.
So I said that in this particular entity, where people have a tremor which is at rest, can look like a Parkinson type of tremor superficially, but they do not have bradykinesia, meaning slowness. And sometimes these patients can be difficult to differentiate between Parkinson and them, and that's where you require this DAT scan, or dopamine transporter scan, which, as I was saying, was not approved in the US till very recently, but we've in Europe have had it for a very long time. So we've been able to collect a number of these individuals with this particular entity. Let's call it an entity.
Could you teach us a little bit about the DAT scan? Because you have had a lot more experience with it. We at UCLA, have done some research with what you said, the Flora Dopa PET. The DAT scan then came available maybe about 5 years ago. We don't use it a lot in our clinical practice, honestly. But maybe you could tell us a little bit about what it is, maybe first of all, and then what type of patients would you consider using this in the UK?
So I think just to keep it simple, essentially it's a presynaptic dopamine marker, and it is abnormal in Parkinson's disease or other Parkinsonian conditions. So it can't differentiate, for example, Parkinson's disease from multiple system atrophy or PSP, but it can differentiate Parkinson's disease or Parkinsonian disorders from, let's say, essential tremor or dystonic tremor, which are conditions where generally you do not get bradykinesia or slowness. So it's useful in situations where the doctor or the neurologist has difficulty differentiating between a tremor condition which looks like essential tremor or where there's a resting component and somebody where he can't say for sure. I can't make out whether there is slowness or not, and I see a rest tremor. It could be like a Parkinsonian tremor, but I'm not sure. That's where you require a DAT scan.
Okay.
But if the bradykinesia is clearly evident, then you don't need it.
So there's the MRI type scans or CAT scans where you see the anatomy. So you see the sort of
structure. Yeah,
the structure. Then this is a type of functional imaging study where you see sort of the cells uptaking things and what sort of the function of these cells can be. And in those, in Parkinson's, there's a couple of different types of scans in research that we do. One is a fluorodopa PET scan, but the DAT scan is a different type. It's a SPECT scan that looks at dopamine transporter imaging. And what we were saying is that in the different types of things that affect the basal ganglia, so the Parkinson's type syndromes, like the Parkinson's plus disorders or regular Parkinson's, it won't help you differentiate those things. It just shows you if there's an abnormality in this sort of area of the brain, but it should be able to distinguish from Parkinson type issues with these other things like essential tremor or these other sorts of dystonia type problems. And in some situations, when it's a complicated tremor that you can't clinically figure out what's going on, it can be a tool that you can use to help in differentiating that sort of weird tremor that looks like it's at rest, but you can't figure out if there's slowness mixed in there. And it may account for a percentage of patients in these studies where we are taking early patients with Parkinson's that may walk in our door and we're trying to get a sense of, does this patient have Parkinson's or not? The SWEDs are the ones that probably have a tremor that's a little unusual. We don't have possibly a lot of other Parkinson features like stiffness and slowness, and those patients may sort of account for this normal imaging. So we see a normal DAT scan, and they may end up having a mix of diagnoses in that category, including what you just said was a dystonic tremor. So a tremor that looks like it has some of this dystonia mixed in there. Does that sound about right? Kailash?
Sorry.
Does that sound about right?
Yeah, I think that's fair.
You're looking at that question. Okay. So, all right, that sounds good. So a couple of other questions have come out. I think one was to understand a little bit more about the X-linked Parkinsons, the Lubog patients that you had described in the Philippines. There was an interest in understanding about that. Could you tell us a little bit about that population?
I think it's a very specific. It's very specific to that population from the. I think it's from Panay in the Philippines, and they get a particular type of. I've only seen one person in my life who came to, who was in the UK, and came to my attention and developed very quickly at a young age dystonia of his neck, and then followed by quite marked Parkinsonism. Because he came from that particular region, we were able to suspect it, and now there is a genetic test for it, which can be carried out to confirm the diagnosis. These people can respond very well to deep brain stimulation surgery, which helps both the dystonia and Parkinsonism. and they can get a very rapid onset, a very rapid progression. So it's a very typical disorder, very different from the classic Parkinson disease.
Okay, so it shouldn't really be
It
mixed in.
shouldn't be a
Shouldn't really
concern
look like.
unless you're from that region.
Okay. There's also been some questions about like dystonia and in the middle of Parkinson's sort of symptoms. So one of our patients asked, I'm a PD patient. During my off periods, my right arm and hand become frozen and that movements and dexterity are very difficult. I've always called this dystonia even to my PD specialist, but is that the correct term of this condition? I don't experience any involuntary movement or contortion of the arm or hand.
So I guess the question is whether you have akinesia, meaning that during your off period are the movements difficult because you have bradykinesia or akinesia, or do you have dystonia? Generally, off period dystonia affects the feet most commonly. Usually happens early in the morning, is quite often painful, and will respond to dopaminergic stimulation. Occasionally you can get upper limb off period dystonia. So without actually seeing what happens, the question about being frozen, that can also be due to akinesia. We like to use the word dystonia where we do see some abnormal posturing. So very typically the feet will go down in an abnormal posture in the off-period dystonia, which you see in patients early in the morning, which I'm mentioning.
Okay, so you like to see, and sometimes like toe curling, sometimes
toe curling, cramping, showing an abnormal posture of the toes, yeah, upwards or downwards, abnormal posture of the feet. So that was what you would call dystonia.
Okay. Could you teach us a little bit about the role of botulinum toxins in treatment of dystonia, and also even specifically in Parkinson's dystonia?
Sure. So there are different strategies one might use in people who have off-period dystonia, particularly if it's early morning dystonia. So sometimes you can use a control release dopamine preparation at night, just before you go to bed, which you hope will work also in the morning. Or you might use a immediate acting dopaminergic drug, such as, for example, we sometimes use a dispersible matopar preparation. Or you might use apomorphine rescue as an injection. Or you might consider using botulinum toxin. The advantage with the botulinum toxin is that you can target if it is happening in a particular pattern repeatedly. So like Indu said, if you notice that every time it happens, the toe extends upwards or the toes are clawing, then you can target the flexors of the toes or the extensor of the thumb, as the case might be, with the botulinum toxin. And the advantage with the botulinum toxin is that it can work for 3 or 4 months, so it gives you relief for a long period of time without having to take extra medication at the time this happens. So it's a strategy one can adopt, but there are different strategies. And every patient is, as I said, individual, and you do decide which is the best strategy for them. One thing doesn't fit everybody.
Okay. Yeah, and I think the one thing about botulinum toxin is it can cause weakness sometimes as a side effect. So if you're targeting an area, you just need to know what the risks and benefits are. It's important that you see somebody who's knowledgeable about patterns of movement and can really help you decide if it makes sense to take that.
Yeah, I've seen a question here about superficial siderosis. I might answer that and say that superficial siderosis does not enter the basal ganglia, which is the part which we know is affected in Parkinson's or dystonia. So I don't think treating the superficial siderosis would help with the dystonia related to the Parkinson's.
Okay. There's been a couple questions about deep brain surgery and dystonia. Would you talk a little bit about the role of DBS, and then if there might be a target that you might pick for dystonia in Parkinson's patients versus other symptoms?
Yeah, I think that's a very good question. This has been a matter of debate because in when you have a patient with simple dystonia or only mainly isolated dystonia, the target which we use for deep brain stimulation is called the globus pallidus. While in Parkinson disease, the usual target we use is a subthalamic nucleus. So when there are people who have a lot of dystonia as part of their Parkinson's or dyskinesia, there has been debate whether one should go for the globus pallidus as the target rather than the STN. But there have been other studies showing that STN DBS can also help dystonia. So my understanding is that if you've got a lot of dyskinesia, it's possible to consider the GPI, the globus pallidus, as an alternative to the STN. But I think this decision has to be made by the functional neurosurgery team. What we are talking about is just simple guidance.
Okay. Could you, Kailash, teach us a little bit more about the camptocornea, so that forward bending posture, or even the Pisa syndrome? Could you teach us about that? Because we haven't really talked about that in a series, and that has come up on other sort of question and answer situations.
Yeah. So the exact cause of why people with Parkinson develop camptocornea is not entirely clear, but I guess it's a mixed picture. So initially the understanding is that there may be an overactivity of muscles which are pulling your trunk forwards, a dystonic process, for example. And at that time, when you put somebody against the wall, they can actually correct themselves and improve their posture. Subsequently, the extensor muscles which hold your trunk back may become weakened. Then the problem remains more constant. So there can be what I call a myopathic, or a change in the muscles in some people who have this camptocornea. Now, treatment can be tricky. People have tried botulinum toxin, etc. The ones where there is a change in the muscles, obviously the botulinum toxin is not going to be very helpful, and their physiotherapy, learning how to keep straight, etc., can be tried to try and strengthen those muscles. There has been some suggestions that, or anecdotal reports, that maybe a dopamine agonist sometimes may contribute to the development of camptocornea. Not levodopa, but a dopamine agonist. And there have been reports of people who have been taking dopamine agonists who have had the camptocornea. When they come off the dopamine agonist, their camptocornea improved. But as I said, not each of these statements I'm making is necessarily true for every patient. Every patient is different, and people have to take into account several factors when they are deciding these things. It's important to remember that.
Absolutely. So there's a question here about exercising and inducing foot cramps and dystonic episodes in the feet. Basically, dystonic episodes in my feet prevent me from exercising. Are there any ideas? It's a vicious cycle, because if I don't exercise, my symptoms get worse. So there's a sort of vicious cycle. Could you speak to that, Kailash?
I think, I don't know what the age of this individual person is and so on. So if the person has a young onset of dystonia and is getting foot cramps or exertion induced dystonia every time they exert, I would keep in mind some of these genetic causes, and in that case I do use an anticholinergic drug. I don't use an anticholinergic in older people, so I know age is a philosophical discussion, but anticholinergics are not preferred in people, I would say, above the age of 60. But if you have young onset dystonia, and on exertion you're getting foot dystonia, and you're in your 40s or something, then anticholinergics can be quite helpful for the dystonia,
Okay.
the dystonia aspect. So it does depend on the individual and the circumstances. If this is happening in an older individual, that every time they're exerting they get the dystonic spasms, then these other strategies which we just talked about, using a timed dopaminergic stimulation, considering botulinum toxin, using a controlled release preparation, all of those things come into context. So it does depend on the individual, the age of onset, etc., etc.
And the reason, just to clarify, that you don't use anticholinergics, and those would be things like trihexyphenidyl is like the main one that we use here, in an older patient, is side effects?
So side effects, so they can get memory difficulty, confusion, a dry mouth, in men difficulty passing water. So there are a number of side effects which can happen with anticholinergics. So you have to use them with caution in older people.
Absolutely. Okay, that's helpful. We've mentioned a couple of these genetic sort of, young onset type PD things. When do you actually order? And I know you work in an academic setting, and it's a little bit different because I think you have a lot of these as part of your research protocols. But for those people that might be in the world and have maybe access to this, but it may not be fully covered through insurances and things like that, what's your general advice to patients who have Parkinson's symptoms that are considering getting genetic testing? What do you think is, in this day and age, a useful sort of algorithm to think about whether to test or not?
So you're right. I mean, the genetic testing we do is more in a research setting because at the moment we do not have any clear disease-modifying drug or anything like that where if, for instance, so there are a number of, this is quite a difficult question to answer. Let's put it like this. At the moment, there aren't any particular treatments which are useful in any particular genetic form of Parkinson's. But there are drugs on the anvil which may be useful in certain genetic forms of Parkinson's. So for example, LRRK2, which is a common genetic cause in particularly in some of the Ashkenazi Jewish population, or Gaucher's disease. So there are, LRRK2 is a kinase, leucine-rich kinase. So there are certain drugs being developed by certain companies which may be useful in people who have the LRRK2 gene. There are certain drugs which may be useful in people with Gaucher's, and so on. So till now I would have said to you that maybe it doesn't matter whether you have a particular gene or not because we don't have any particular treatments for that. But this may change pretty quickly in the next few years because it is possible that people who have a certain genetic form, there might be particular treatments available for them in the near future. Not yet, but maybe in 4 or 5 years. At the moment, we would say that going and asking for a genetic test for yourself doesn't really, it's not warranted. But in the research setting, certainly it's warranted.
Okay. You mentioned the one patient that you had on the slide deck that had the video with the one misdiagnosis of cerebral palsy. There is some interesting overlaps with cerebral palsy and the movements that you see and the dystonias. Is there much to do with cerebral palsy? Are you seeing many patients that were diagnosed with that as children or through life that then end up having, a presentation to your clinic and you diagnose them with something different?
Yeah, so again, a very good question. So this particular condition called Dopa responsive dystonia can manifest, as I said, in many different ways. And one of the ways it can manifest is what looks like cerebral palsy. So these are children who have dystonic spasms. They are thought to have cerebral palsy, but they might actually have Dopa responsive dystonia. And what we suggest is that any child who has young onset dystonia should be given a trial of levodopa. You have nothing to lose. And if they respond, you might be suspecting Dopa responsive dystonia, and you can do the genetic testing or you can do a CSF analysis to look at the particular metabolites in the CSF. So this is a diagnosis which should not be missed, that of Dopa responsive dystonia. And just to make that point again, that some of these people can present at the young onset with the foot turning in. Some may look like cerebral palsy. They might be in a wheelchair, thought to be cerebral palsy. And some may present later with Parkinson's disease. and they're all linked to the same gene. Now, why do some people present in one way and the others present in another way? We don't know. Nobody knows. Whether there are environmental factors or other genes, uh, you know, causing their expression to change. We don't know the answer. But it's a very interesting, and we are seeing this with other genes as well, that some genes can present in a particular way and in another way. So we call that phenotypes. One gene can produce many different phenotypes.
That's great. Yeah, it's very complex, it sounds like. Some of the questions here about yoga and dystonia, I can answer those on a different session. We don't need you here, Kailash, but
No, you tell us. No, I'm interested in learning about yoga and dystonia.
I mean, I think that yoga, along with these other physical therapy and many things, you know, can work with motor control and help rewire some things. And I think it's, you know, along with some of these other modalities, if you have somebody who has turning of a muscle or tightness of a muscle, certainly, you know, stretching it and using sort of you know, many of the movements that we do in the asanas of yoga can be helpful, and even some of the breath work can possibly help with, you know, some of the pain and the anxiety and things that may come along with off episodes. So I'm a big proponent, but we don't have to waste our precious time with you, Kailash, on that. But I'm proud of my group here that they're talking about these complementary therapies. I love it, qigong, yoga. But one thing that I wanted to
no, but I do want to make a comment here. I think any sort of exertion, whether it be exercise, whether it be yoga, whether it be a Tai Chi class, whether it be swimming or whatever, it's become very clear that from a number of studies that people who exercise compared to those who don't exercise, whether it be Parkinson's disease or be Alzheimer's disease or any of these, those who exercise are clearly doing better. And then the question is, how do we define exercise? So what is exercise? And this is something which, Indu, perhaps you can correct me, but at least in the UK, we tell our patients that they need to do a walk, if they can, 30 minutes or so, 3 to 4 times a week. Yoga, as you said, a Tai Chi class or something like that. But it's important to do some of these activities. I don't know, what do you advise them?
Yeah, I think exercise and this lifestyle, and you and I both practice very similarly in terms of, you know, I think our approach to telling patients holistically about the things that they can modify and empower themselves with in terms of the exercise, eating right. I mean, you live that kind of lifestyle yourself. I know you're very fit, avid, you know, biker and runner and things like that. And I think it makes a huge difference both in the motor and non-motor realms of Parkinson's. So absolutely, if you can get an hour in a day, that would be great. But if not, at least 20 minutes of something cardio, and then the stretching and the mind-body approaches are amazing. Kailash, I wanted to just spend, you know, we have about 5-6 minutes left. You are a huge, you know, fount of knowledge, and you've been in practice and seen sort of the ebb and flow of these different medications coming in. And I just wanted to find out your opinion on sort of what are your thoughts of the future, you know, sort of game changers that are in the pipeline for Parkinson's patients. Give some hope to the group out here about what they can expect in the future, as where you really think that this field is going, and how they can maybe get involved with some of the advocacy and where they should be spending their time, whether it be, you know, in research studies or looking at this global thing. I mean, there's a lot of activism out there, so maybe you can guide us a little bit in the last few minutes.
Absolutely. I think there's a lot of activism. It's great to see, you know, I think there's a lot of positive energy going into research. You know, some years ago, I thought we had sort of come to a sort of, we had sort of slowed down. If you're thinking about it as a river, we seem to have, you know, slowed down the flow, but things have really picked up, and there are so many different avenues which are being you know, explored, and I'm really very optimistic that we're going to see some dramatic changes in how we think about treatments for Parkinson's in the next very soon, in the next 4 or 5 years. And this can be in a number of different directions. So you know, people are talking about, as you heard, about anti-diabetic drugs such as you know, exenatide. We heard about drugs which are being developed which are looking at the genetic pathophysiological mechanisms and trying to block antibodies and so on, as is happening in Huntington's and other degenerative diseases. So there is so much, so many different directions that we are going, and I think that from the patient advocacy side, it would be great if people would, and they are participating in trials, etc. So there will be many more trials, I'm sure, on the anvil, and I think that we are going to see some remarkable new things happening in the next 4 or 5 years in the field of Parkinson's. I'm pretty confident about that.
And in the last maybe 3 minutes, I think just speaking about the exercise piece and just even other lifestyle approaches, when you see a patient that's newly diagnosed with Parkinson's, let's say, or you first meet them, what are the types of lifestyle things that you do believe in, that you tell them? And you don't have to say anything just because you and I are friends and that, this is
No, I tell them to meet Indu and learn about yoga. No, I think we probably do the same as you do. We tell people about. I think exercise is something which we are really harping on a lot. But I think it's more or less the same everywhere now. What you advise.
You believe that it makes a difference. I mean, as a person.
I personally think it does. Yeah.
That's really good to hear. So maybe, Kailash, I'll just give you the last 2 minutes to give some hope to our audience here, just, from your perspective as sort of, where you sit and you're looking at the perspective. I know you said that there's a lot of things out there that are promising in the pipeline, but, maybe thinking about this global diaspora of, sort of information and education, how can patients really make a difference? I mean, you're very active in India. There's been a lot of focus in Africa as well about medications that aren't available. Where do you think we can really kind of make a difference to help every patient out there with Parkinson's in the world?
Well, I think what I want to indicate is how we can learn from each other. I'll end by telling you a very interesting story. There was an Italian Christian group who sent one of their sort of directors or whatever had been to Africa and went to Ghana and saw that there were a lot of patients with Parkinson's who were not on treatment, obviously, because they didn't have the money to be able to afford levodopa. I don't know whether you heard about this story.
Yeah.
So they send a young neurologist, Robert Chilia, to Africa, to Ghana, to go and help these people and start them on treatment and to diagnose them and so on. So this gentleman goes there, this young neurologist, and he starts many of them on treatment, and he realizes that what was happening is that unlike the patients he had in Italy, where they would be diagnosed, they would be starting on treatment, and 4 or 5 or 6 or 7 years down the line they would develop fluctuation in dyskinesia. But the Ghanaian people were developing dyskinesia quite early on. So the question was why? And what he realized is that it was not the dose or so on, it was the duration of the disease. So this idea we had that we will keep the levodopa up our sleeve and only use it later, this particular study led to a sea change in our understanding that we don't need to wait. We can start the levodopa early in people so that we give them a better quality of life while they can enjoy the early period of the so-called honeymoon period, etc. And the dyskinesia that are related to the duration, of course also to the dose, but mainly to the duration. So don't delay, start today was a very nice editorial which Tony Lang and Susan Fox wrote in relation to this article. Now, if these people had never been to Ghana, this would have never happened. So what I'm trying to say is that we are one, we are one people all over the world, wherever we are, and these diseases are there everywhere. So we can learn from each other, and we also provide hope to each other that we will try and find new discoveries so that we can together try and overcome this problem. That's what I've got to say.
That's really beautiful. And I truly believe that too. And which is why we've been trying to have so many people from all over, all our thought leaders from all over the world on this to help inspire. And we'll definitely make this available on YouTube and with World Brain Day, and just sort of the excitement and the passion that's been growing around just trying to help every patient out there with Parkinson's. And we're going to have all the PD Avengers on this show as well to highlight what their causes are. And I think it's just so, I think COVID has unfortunately or unfortunately, you know, banded us together as one. I think people across the world, we realize that something that happens in China can affect, you know, me here in Santa Monica and you in the UK. So I think just like that, I think we can hopefully take this energy and unite around this cause of Parkinson's and helping every patient out there. So I so appreciate that message. It's really beautiful. And thank you everyone for your time. And thank you, Kailash, especially for taking the time to join us. I will send it back to you, Anissa, for our final wave goodbye.
Great, thank you. Thank you so much, Dr. Subramanian. Thank you, Professor Bhatia. It was wonderful. Thank you everyone for joining us today, and let's wave goodbye to all of our friends, like we said, wherever you are. Have a great day.
Thank you.